Thank you for joining us today for this media briefing about COVID-19 in Idaho. My name is Nikki Forbingor and I'll be moderating today. Please note that everyone should be muted unless they are speaking. American Sign Language interpretation is available today. You can search for interpreter Stubbs and hover over the three little dots in his video window and it will lock it in place on your screen. To start us off today, Health and Welfare Director Dave Jeppesen will provide some opening remarks, followed by Public Health Administrator Elke Shaw-Tulloch, Dr. Christine Hahn, and Idaho Immunization Program Manager Sarah Leeds. And with that, I will turn it over to Director Jeppesen.
Well, thank you, Nikki, and welcome to everybody to our press briefing today. I'll take just a few minutes and provide an overview of some key metrics related to COVID. First, I'd like to start with vaccinations. We've actually crossed a milestone with 80% of those 65 and older receiving at least one dose. And for our population 12 and older across the state, we are at 54, just a little over 54% with at least one dose. And thank you to all of you who have chosen to form of an outbreak taking place. But what I'd like to spend some time today talking about is hospitalizations, and we'll show a little chart here to help me with that. And so this chart daily average of 466 COVID-19 patients in the hospital. As of last Friday, August 28th, our daily average was 457 patients in the hospital. And the thing that's really interesting is that it's actually rising much more quickly than it did last winter. So if you look at how quickly the line is increasing here for COVID patients in the hospital, it is going up much more quickly than it was last winter. And we fully expect the daily average census for this coming week to exceed our previous peak. For COVID-19 patients in the ICU, that's the next line, the second line down on this chart. You can see that our previous peak was back on the week ending December 19th, where we had 116 patients, a daily average of 116 patients in the ICU. And for our week ending last Friday, we were at 141 ICU patients, far exceeding where we had previously been. And then the last line is ventilators, our individuals on ventilators with COVID-19. Our previous peak was again back on December 19th with 60 patients on, or a daily average of 60 patients on a ventilator. And you can see our week ending last Friday, we were at 76 patients on a ventilator. We expect this to get worse in the coming days and weeks. And this is going to severely impact healthcare capacity. It will impact not only access for COVID-19 patients, but it'll impact access for anyone seeking healthcare. As the governor mentioned earlier today, we're teetering on the edge of crisis standards of care. The healthcare systems and the state are doing all we can to avoid crisis standards of care. As the governor mentioned, we coordinate resources daily across the state to see where resources are and who can help out where. The governor announced today providing financial help, as well as bringing in up to 370 additional resources to help the hospitals with and the healthcare systems with the surge of patients that we're seeing. And Elke will provide some more details on that in just a minute. But the real answer is up to all of us, which is to choose to get vaccinated and to take precautions such as wearing a mask indoors and physically distancing, particularly indoors. The vast majority of hospitalized patients are unvaccinated. Early on in this pandemic, I had to make two decisions. One was whether I was going to get vaccinated myself, and the other was whether I was going to recommend to all of you, all 1.8 million people in Idaho, whether you should get vaccinated as well. That's a responsibility that I take very seriously, and a recommendation I would only make if I was extremely clear and confident that it was the right recommendation. I have watched with extreme interest the clinical trials, the data, the amount of scientific research, the robustness of the clinical approach for these vaccines. And it is after watching that up very closely and very detailed that I feel very confident in myself getting vaccinated, which I've done, and in recommending to all of you to get vaccinated. And so I would again invite all of you that haven't been vaccinated to choose to do so. The vaccine is safe and effective, and it is the best way we have for us to bring this pandemic to something that's manageable. And with that, I will hand it over to Elke.
Great, thank you, Director. Appreciate your comments very much. I'm going to cover, as the Director mentioned, a few items related to a funding announcement that the Governor made this morning, or just a little while ago. So to start with, the department, in cooperation with the Governor's office, the Idaho Office of Emergency Management, and other state and federal partners, have been working with healthcare to support their resource needs. You've heard a lot of detail information from the Director about the onslaught of patients that hospitals are facing and the resource constraints that they were under. We have a wide variety of solutions that we're bringing to fruition, and then some that we have under development. The Governor mentioned many of these solutions in his remarks earlier today at 12:30. For example, we have 200 additional medical and administrative personnel coming to Idaho through a contract with the U.S. General Services Administration, or GSA. We have 20 additional clinical staff coming from the Department of Defense as part of their medical response team being deployed to Kootenai Health in North Idaho. We have up to 150 National Guardsmen, Idaho National Guardsmen, to provide logistical support to help do things like screenings, environmental services, lab work, and other duties. We're also establishing 3 monoclonal antibody treatment centers around the state, and Dr. Hahn will be giving you more information about that. There are new funds that are going to be made available immediately after this call to help Idaho hospitals attract and retain medical staff. I'm going to get into more detail in just a moment. And also, as the Governor mentioned, there's a waiving of licensing fees for retired or inactive nurses so they can activate their licenses to re-enter the workforce more easily. Those are all very important strategies that we're working on to help support our healthcare systems from across the state. I want to provide some additional information about the new funds that are being made available to healthcare, both hospitals as well as freestanding primary care and urgent care facilities in Idaho. For the hospitals, $4 million is being made available. The funding will be allocated at $1,000 per licensed bed. The funds can be used to address a variety of hospital constraints and emergent needs related to the massive influx of COVID-19 patients, including for the following uses. They can use them to relieve staffing shortages, including retention bonuses. They can hire new staff or start their staff at higher rates of pay to be more competitive. They can hire temporary staff. They can pay overtime hours. They can pay for lodging and support for traveling healthcare staff. Staff training. They can purchase temporary physical space support. So we know many hospitals have told us that they're already looking at non-traditional spaces to set up healthcare provisions. They can also use these funds to establish locations for the administration of monoclonal antibodies. So public and private hospitals operating in Idaho are eligible, and they can submit a simple attestation form. We want to make it as easy as possible for them to request and receive these funds. They will be available on the coronavirus.idaho.gov site under the Resources for Healthcare Providers tab and the section titled COVID-19 Funding Support. And I believe that they're available right now if you go and look at our site. The next funding opportunity for the freestanding primary care and urgent care clinics is for a total of $1 million that will be available to these healthcare entities in the form of grants to provide financial support to address their constraints and emergent needs. Similar to hospitals, these clinics are also experiencing constraints when it comes to staffing. Funding is available on a first-come, first-served basis, and it will be divided up into several funding buckets, or categories, if you will. So small primary care and urgent care clinics, freestanding clinics that see less than 2,500 patients a year are eligible for $1,000. Medium-sized clinics, that's 2,500 to 10,000 patients, are eligible to receive up to $250,000 in a grant. And for large facilities, which is more than 10,000 patients a year, they're eligible for $400,000. So interested freestanding primary and urgent care clinics can complete the funding application. That's at the same location, coronavirus.idaho.gov, under the Resources for Healthcare Providers tab and the section titled COVID-19 Funding Support. We hope that our healthcare providers that are under these serious constraints will take advantage of this, and we're happy to be able to provide this funding. And also, I wanted to take a second to provide an update on our school testing funding that we've talked about the last couple of weeks. As a follow-up from last week, $30 million is now available for schools K through 12 that choose to avail themselves of this flexible funding. It's a simple registration form for these funds. That can be found now at the State Department of Education's website, which is www.sde.idaho.gov, under the section titled 2021 to 2022 Back to School Guidance. So I wanted to follow through from our commitment to making that available the last couple of weeks, and you can find it there for any school who chooses to take that on and take advantage of that funding opportunity. With that, I'm going to turn it over to Dr. Hahn to tell us more about monoclonal antibodies.
Thank you, Elke. I am here to talk about the monoclonal antibodies. You have probably heard some of the news from the governor's announcement, but we want to make sure that you're aware of what's happening in Idaho. The governor would like to see monoclonal antibody infusions increasing in all parts of the state. These drugs are given by IV treatment, so they're not something you can take at home. They're something you need to go into specialized treatment centers, and it's just an added burden for hospitals and providers who are very busy taking care of patients or vaccinating or taking care of patients with non-COVID conditions. So we are trying to work with partners to set up these specialized infusion centers. These antibodies are not a panacea. I'd like to emphasize, and I'll emphasize probably several times in my statements, that the vaccination is the best way to prevent COVID, the best way to prevent hospitalization, the best way to prevent death from COVID is by vaccination. However, it is nice to have one more tool more widely available in Idaho, and that is the purpose of this work that we're doing now. The idea with these medications is that people who are at high risk of ending up in the hospital, so these could be people who are 65 and older, people with obesity, diabetes, lung conditions, heart conditions, they can come to one of these as soon as they test positive if they're in one of these high risk groups, but they don't yet need to be in the hospital. Right now, they're not too sick. They can come in and get an infusion. It takes about an hour plus some observation time, and then they can go home. Many people have reported rapid improvement, and you all may be aware that this was a type of treatment that President Trump received when he had COVID, and more recently, the governor of Texas. So certainly it is availed by people who realize the potential benefit of these medications, and it has been shown in clinical studies to be effective. Like the vaccine, it is under emergency use authorization. It is a new treatment, relatively new treatment. It is still under emergency use authorization, but the clinical studies show that it is very safe, very well tolerated, and that people, the clinical trials are reporting about a 70% reduction in the risk of getting hospitalized with one of these monoclonal antibody treatments. So I'll say it again. I'm trying to think of a good analogy. I think of it as a seatbelt and an airbag. The vaccine is your seatbelt keeping you in place. Don't feel like your airbag's going to save you. The airbag maybe is that monoclonal antibody once you get in an accident, but you don't want to rely on that. You want to be vaccinated, and that's your best protection. But for people who are not vaccinated, who are at high risk, who might end up in the hospital, the availability of these is going to be a really good option. We're hoping that as early as next week, we might have a monoclonal antibody infusion center opened up in northern Idaho. Details are still being worked out, so more details forthcoming on that. So I'll leave it at that. And I think Sarah Leeds is next, if I'm correct.
Thank you, Dr. Hahn. Yeah, good afternoon, everyone. I'm really pleased to be able to provide some COVID-19 vaccine updates amidst all the sobering hospital capacity data. We do have some glimmers of hope when we look at our COVID-19 vaccine administration data. As the Director Jeppesen said, as of August 30th, yesterday, we have 733,629 Idahoans who are fully vaccinated. And about 87,000 more in the process of they've had one dose of a 2-dose series. Each day and each week, we are seeing more people choose to get the COVID-19 vaccine. As you know, or as you may know, on August 13th, the FDA and ACIP, the Advisory Committee on Immunization Practices, approved and recommended 3rd doses of Pfizer and Moderna, which are both the messenger RNA vaccines, for moderately to severely immunocompromised people. And I can tell you that since August 13th, 3rd doses of both Pfizer and Moderna vaccine have been administered to 2,255 people. We also know that there is a lot of confusion around 3rd doses versus booster doses. And one of the questions we're hearing quite often is, what is the difference between a booster dose and an additional or 3rd dose? And the answer to that is sometimes people who are moderately to severely immunocompromised do not build up enough or any protection when they first get the vaccine. And when this happens, getting an additional or a 3rd dose in this case of the vaccine for both Pfizer and Moderna can sometimes help them build more protection against the disease. And in contrast, a booster dose refers to a dose of a vaccine that is given to someone who built up enough protection after the series, the 2-dose series, in this case, Pfizer and Moderna, but then that protection decreases over time, and it's what we call waning immunity. Right now, 3rd doses should only be administered to immunocompromised people. We've been told that the ACIP will be meeting in mid-September to review the data on booster doses for the general population. And there's been a lot of communication in the media about that. If ACIP recommends that, we anticipate that the focus will be on long-term care facility residents and staff, healthcare providers, older adults, both 65 and older and 75 and older. And as you can tell, this focuses on the highest risk population and also the time interval since they received their 2nd dose. So we will wait for that information from ACIP. But in the meantime, the Idaho Immunization Program is planning for booster dose administration, and we're working in partnership with our local public health districts and COVID-19 vaccine providers across the state to be ready to vaccinate those who fall into the category that CDC recommends if and when they recommend booster doses. So Nikki, with that, I'll hand it back to you.
All right, thanks, Sarah. Okay, so we'll now take questions from our media participants. Please raise your hand in WebEx or type your question into the chat area. When I say your name, please unmute yourself and announce your name and media outlet before asking your question, and please remember to clear your hand when you're done. So I see Audrey Dutton had her hand up first.
Good afternoon, Audrey Dutton with the Idaho Capital Sun. This question is for Dr. Hahn. How will Idaho staff these infusion centers without pulling staff away from other settings? And how can we be sure that the patients who actually qualify will seek out this care with so many people who would qualify for this, who are high risk, only showing up in the ER now when they're well past the point of Regeneron helping?
Right. Thank you, Audrey. Those are both really incredible challenges that you have pulled out there. You're absolutely right. So first of all, the partners that we're talking to up north, and of course includes Kootenai Health, but also some other partners in the area. The idea is to not pull away from hospitals, to not pull away from resources that are already overworked and overstaffed and that can't do it. These are all voluntary, and these are clinics and agencies that feel that they do have the resources to bring to the table. As you can imagine, it can be potentially something that is done during workday hours, not 24. It doesn't have to be standing up 24/7. So we're hopeful that there's a way to work this in without pulling away from hospitals. Regarding the 10-day, as you know, people need to be treated quickly. The sooner the better. And it has to be within 10 days of symptom onset. And we know that a lot of people will let things go for a few days. You know, I think it's just a minor cold or something before they might seek care. Then there's a lag maybe in testing results. And that is a big problem. But one thing the state has committed to do is, as these infusion centers roll out, we will work on ensuring the public is educated, working with the local health department, working with the health facilities that are involved to make sure that we're all working together on this. We will help support messaging to the public and to providers to let them know about this availability, because I think a lot of people, if they realize, hey, there is a treatment that might help me, maybe they'll go in and get tested sooner, and that will be the message to get tested so you can get treated. Kind of like we try to do for flu, you know, try to change the culture there where people used to say, oh, there's no treatment for this. But now many people are aware that there are antiviral medications for influenza. So we will have to work very hard on both those things that you addressed.
Okay, our next question is going to come from Melissa Davlin.
Hi, Melissa Davlin with Idaho Reports. I was wondering about testing capacity and backlogs across the state. Do we know how many tests how many samples are still in the hopper waiting to be processed? And do we have the capacity to even know if we hit that mid-October worst case scenario projection of 40,000 or 4,000 cases a day?
Yeah, thanks, Melissa. I'm going to turn it over to Dr. Ball, who is on the call.
Thanks, Melissa. These are all very good questions, and they're questions that we're really working with our clinical laboratory partners to identify the scope of any testing shortages. So far, what I'm hearing on a national level is that there are ample resources for PCR-based laboratory testing. Where they are seeing some constraints are for the over-the-counter non-prescription use antigen test systems. Those seem to be in quite high demand right now, and manufacturers are having difficulty meeting those supplies. Although the good news on that front is there are some new test systems that have recently received emergency use authorization, so the forward-looking projections are that there will be increased supply for those over-the-counter non-prescription based test systems. So we will be fielding a survey to Idaho clinical laboratories later this week to try to get an idea of where their capacity constraints may be, and then look to see how we can best support them in anticipation of things getting worse as this current wave increases.
That's forward-looking, Dr. Ball. Along with that, do you have an idea of what the current situation is, especially, you know, I heard that there's a bit of a backlog in North Idaho right now, especially.
You know, I don't have any firsthand knowledge of that, although I have heard anecdotal reports of shortages for some test systems. But I know the state's largest test provider up there, Kootenai Health, is able to keep up with their PCR demand. I should have additional information on constraints shortly, but I don't have any numbers for you at this point.
Thank you.
Okay, our next question is going to come from Heatherann Wagner.
Thank you, Heatherann Wagner, KPVI. This goes with testing as well. Is there anything being done to make the process easier? Because I know you have to go online, see if you're eligible, and then if you go to like one of the drugstore drive-thrus, it's 3 to 5 days minimum. So I know people are quarantining until then, but is there anything being done with that process to make it faster or easier? Thank you.
Dr. Ball, do you want to continue on?
You know, I think for the retail pharmacy-based testing, since that's all largely send-out testing, there are some additional delays associated with shipping of those samples. I know that there are availability at some of the primary health clinics, and they're working with a local laboratory, so they should have fairly good turnaround times. So I think that what we're seeing with this big increase in testing demand, there's going to be a bit of a lag until folks can get restocked and reloaded, I guess, and ready for this big testing increase. And again, most of the information that I'm hearing is all anecdotal in nature, and so we're really trying to get a better census of what's going on at testing sites. So by our next, I hope by our next press conference to have some more actionable information.
Okay, our
Thank
next
you.
question. Oh, sorry. Our next question is going to come from Hayat Norimine.
Hi, thank you. My first question has to do with, so we've been hearing that the surge is worse in the past, affecting younger patients. There's more ICU patients with COVID, more ventilator patients with COVID, more hospitalizations with COVID. So are public health officials pushing for or recommending more restrictions? If not, why not? Why is this surge different than in the past when we had limited large gatherings?
Yeah, thanks, Hayat. I know that we can address this briefly in the last, I think the last of the press briefing and the press briefing before. We know that part of that is that this go around, we have certainly, solutions to the problem, which is, as the director has pointed out, we have the vaccine available. But I'm going to turn it over to him to see if he'd like to expand upon that.
Great, thank you, and thank you, Hayat, for the question. Yeah, the short answer is that we have a different situation than we did last time. One is that one of our severe constraints was PPE last time, which actually even kept our hospital system even more constrained. We do not have any, at least that we know of, any PPE constraints, so that's different. So there's more supply there. But probably more importantly is that we have the vaccine available, and that is the best tool we have, the main tool we have to bring the spread under control and to bring this thing to an end. And so that's our messaging has been for individuals to get vaccinated, and we've talked about that on this call already. And then we are actually recommending that people follow the CDC guidance, which lays out some clear guidance around if you're indoors, you should wear a mask and you should practice some physically distancing while you're indoors as well. But the main tool we have is vaccination. We didn't have that last time, and that's where the bulk of our focus is at this point in time.
Okay, our next question is going to come from Madelyn Beck.
Hi there, this is Madelyn Beck with the Mountain West News Bureau and Boise State Public Radio. I was just wondering if there's been efforts to connect hospitals and systems in Idaho with others in neighboring states to potentially share resources or work back and forth. I know that in situations we've had to send ICU patients elsewhere or over state borders. So I was just wondering if there's any larger strategy to connecting all those systems.
Yeah, that's an excellent question, and the answer is yes, in short. We work very closely, our preparedness team here, working in concert with the Idaho Office of Emergency Management. We work continuously with our neighboring states with their preparedness folks as well. So there are constant dialogues about what resources are available. Hospitals, of course, already have their own relationships, and they have continual requests for receiving patients as well as requests out for sending patients out if we need to transfer them. A good example right now that I can share with you is that we've even been able to work with the Veterans Administration to have a mission assignment for the Boise VA as well as the Spokane VA hospitals have the ability to take non-VA patients. And so the Spokane VA it's certainly one area where, in northern Idaho, we have been working with them on new patient transfers. So the conversations certainly happen all the time. The problem that we face right now is that everyone is constrained, all states around us, all states across the nation, and bed availability and staffing availability for those beds that are available continue to be challenging, but we definitely work with states across actually the whole nation.
Gotcha. Thank you.
Mm-hmm.
Okay, Kyle Pfannenstiel is going to have the next question here.
Thanks, Nikki. Kyle Pfannenstiel with the Post-Register. I have two questions, and excuse me if I missed the answer for the first one. A few months ago, y'all displayed a graphic of the rate of vaccinated Idahoans who got sick, hospitalized, died from the virus. I'm wondering if that has changed anytime since your last publication of that.
I believe Dr. Turner was able to join us via her phone. Oh, yeah, I guess you're on the camera now. So Kathy, do you want to take that?
Sure, thanks, Elke. Kyle, great question. What I will say is that no, the proportions have not really changed since that last update. You will see that on our dashboard we do display the rate per population. So we display a rate of cases, hospitalizations, or deaths by the vaccinated population versus the unvaccinated population. And you'll see that there's a vast difference in those numbers. Those who are unvaccinated are over 7 times more likely to be hospitalized in Idaho.
First?
I'll go first and let Kathy give the real answer. No, I think there's a couple. I think we both have some ideas. That's a great question, Kyle. We've noticed it too. I think one thing for sure, Dr. Ball already addressed this a little bit. Some of these tests that are being more commonly used now, home test kits, that kind of thing, are not always reported to public health. So we always knew that was happening, but we're not alone across the nation. Public health is worried that we're not hearing about every test by any means. And that's one reason why our hospitalization data, our outbreak data, our other data really helps inform this outbreak very well. The numbers of cases are helpful, but as I think Dr. Turner may have some more thoughts on this, but the numbers of cases have never been an absolute truth by any means, and we think that's probably even more true now.
Yeah, Kyle, this is Kathy Turner, and I think Chris had it right on the nose that surveillance data are the tip of the iceberg. We have never thought that we're hearing about every single illness out there, and the situation is a little different now with some of these other modalities for testing, such as at-home testing, that public health is never going to know about. People are taking the test and they don't have to tell anybody, frankly.
Okay, our next question is going to come from Nicole Camarda.
Hi, this is Nicole Camarda with Idaho News 6. My question goes along with Karen Lair's in the chat. We both are talking about the same thing. Governor Little mentioned that there were 4 available ICU beds, but as of yesterday on the state's website, it says that there's 72 beds listed. So I'm wondering if we could learn a little bit more about that. And also with the ventilators, I don't know if this needs to be a separate question, but it shows in the data that you just showed that there's a record number of people on ventilators, but the data looks pretty consistent over the last few weeks at least with the number of people on ventilators. So can you kind of explain the data there, please?
Yeah, I'll start out and then I'll have Dr. Hahn, who's also been working on this, follow up afterwards. So certainly, as you're seeing on the coronavirus site, it does show that we have 72 ICU beds available across the state. And the governor's remarks showed a different picture. And we have daily calls with the hospitals, operational level calls, and did put a request out to them to help us understand that a little bit better. And certainly we know that the data that we have on our website indicate not just adult ICU beds, but it also includes pediatric ICU beds, and it also includes all beds total in the hospital. But what we really hear on the ground level is that ICU beds, of course, have to be staffed. They're short-staffed, so they can't necessarily use those beds if they don't have the staff to provide that. The data are changing minute by minute, and we hear, from the hospitals that they might have a bed available, now, and 10 minutes later it's gone. So the bed availability is constantly changing, and what we post on the website is sort of that static number, that point in time where they're reporting to us. And like I said, it also includes both pediatric and adult ICU staff beds. Total beds. The picture that they paint, like I said, when they're, when we're talking to them, is a very different picture. And I'm going to ask Dr. Hahn, Kathy, if they want to add to that.
Yeah, thank you, Elke. A couple things, and thank you. A little bit of a repeat, but first of all, the numbers that we get come from the hospitals, and the questions. What questions are the hospitals answering? Those are questions designed by HHS, and every state asks the same questions the exact same way, so that when you go out and look at the federal sites and the whether it's CDC or HHS, you'll see the same questions have been asked the same way across the country, so that there's a good picture of where are the bed shortages and which states are suffering the most, if you will, with bed shortages. So we don't create the questions. We help administer that so that data can flow through us, and we have awareness of the answers. But those are our standard questions. And as Elke already alluded to, the way that the ICU question was asked, and a year ago when we first started doing these numbers, it was thought that pediatric beds were probably not going to become a big issue or not. So they weren't pulled out. They were just asked, how many ICU beds do you have available? And now we realize that it's really important that we separate out adult beds from pediatric beds, from like neonatal intensive care unit beds. And we've actually had conversations over the past several days, and we're hoping to change that. Those questions have already been added. We can't take away, we can't change HHS questions, but we can add to it. So we are starting to ask the hospitals to help us understand better and to separate out, so that we know how many of those are pediatric beds, for example. So, because we agree that number right now doesn't represent what we're hearing from them on our daily calls with the hospitals. The other thing, and Elke already alluded to this, is what we heard on the call today is, yes, we have some open beds, but we don't have the staff to the ICU staff, which is a very specialized, highly trained staff. We don't have enough ICU staff right now to staff all of our beds. So that's playing a role in there as well. The last thing I'll mention is the numbers that we have on our site today came from yesterday. And it's just one more thing, but what we heard from the hospitals this morning was an increase in their numbers of COVID cases even since yesterday. So I think all those things are playing a role. We are going to be changing that site. We didn't want to change it until we fully understood it and we make clear what we're doing for transparency. But we agree the numbers that we're showing right now are not reflective of what we're hearing from the hospitals, and we will be changing that.
Thank you.
Okay, our next question is going to come from James Dawson.
Hey, James Dawson with Boise State Public Radio. I'm sure several people on the call could answer this, but we heard last week that Kootenai Health was moving towards asking the state to implement crisis standards of care. Have they officially asked at this point? How quickly could these steps be worked through? And has the Crisis Standards of Care Committee met yet to discuss, their application or any other potential, things that might need to be worked through beforehand?
Yeah, thanks, James. No is the response. They have not made no hospital has made any official application requesting crisis standards of care. There's a lot of conversation about it due to the stress and strain of the hospital, but they have not made any formal requests across the state, including Kootenai Health, for crisis standards of care activation. And I'm going to, as the person who leads our Crisis Standards of Care Activation Advisory Committee, I'll turn it over to the director for any additional comments they'd like to make about it.
Thanks, Elke, and thanks, James, for the question. I would just say that we we do two things. One is we continue to work very hard, as do the healthcare systems, to try to avoid crisis standards of care. And that was really the impetus behind the governor's announcement this morning around the additional resources, as you heard just described. One of the biggest constraints we have is not beds. It's actually people to staff the beds that when we have those. And so that will hopefully push this out, and hopefully we can avoid crisis standards of care. Having said that, as Elke said, the process is that a hospital would make a request to say, we've exhausted all of our resources and that we now are requesting crisis standards of care. I won't walk through the nitty gritty of the protocol that would do that, but basically that would be a request made to us through our state comms unit. And then our protocol would have us responding to that request within 30 minutes. And then within 30 minutes of us kind of getting with that hospital to go through the situation, within the next 2 hours, we would convene somewhere between 30 minutes to 2 hours, we would convene the Crisis Standards of Care Activation Advisory Committee to review the situation and make a decision about whether crisis standard of care is warranted. And the short way to say that is we are prepared 24 hours a day, 7 days a week, that when that request comes in, and no more than 2.5 hours will go by before we've made a decision about that request, and likely much quicker than 2.5 hours.
Thank you.
Okay, our next question is going to come from Kevin Richert.
Hi, I wanted to follow up. We talked last week about the challenges that you're facing trying to get a handle on what's happening in the schools with cases. We know the childhood cases are going up. We know those numbers are increasing in the aggregate, and we're seeing some schools closing or going online. What are you doing at this point to try to get a handle on where those hotspots are and to try to get out ahead of problems in the schools before they reach a point of closure or going high?
That we know our local public health districts are continuously in conversation with them and working with them on a variety of protocols and advice and recommendations. But I'm going to see if Dr. Turner, who works constantly with the local public health district epidemiologist, if she has any more specific details she wants to share.
Yeah, thanks, Elke. Kevin, one of the things we've done is we've made sure to provide funding to each of our public health districts to maintain at least one person full-time in their public health district to serve as a school liaison. And the role of that person is really to be in the community, they're local, and to have those conversations with the schools, to be there for technical assistance, to be there to help think through when they find out like a staff person or a student might have gotten a positive test or maybe is being tested because of an exposure. So that's one critical thing that we've done, is to provide that local level service and resource to the schools. Some of our public health districts have 2 people assigned to that role. So it's really happening at the local level, but of course we are also working with our counterparts at the state level to make sure that we're disseminating guidance, information, recommendations through our partners to make sure the messaging is the same. And I will just tell you that we have had 3 hits on our registration site. There's been 3 school districts already reaching out to us, looking for funding to implement a testing plan. So I think that's going to be a critical strategy moving forward.
Okay, our next question is going to come from Hayat.
Other question is related to the uptick in COVID-related hospital admissions among those 70 and older. So I'm seeing that the biggest increase was among those that are 70 years old or older compared to the previous week. I'm wondering if you could explain that, or do you think that's still mostly unvaccinated patients, 70 or older? Is it because they could potentially have more underlying health conditions and could be more vulnerable to Delta. Just wondering if someone could elaborate on that a little bit.
I see both Dr. Turner and Dr. Hahn nodding their heads. So Kathy, do you want to start since you're closer to that data?
Oh, well, thanks, Elke, and I'm sure Dr. Hahn will have something to add. But Hayat, yes, to all of the above. There's multiple reasons why you might be seeing that, but I want to point out that there's increases in all age categories. There's not one single age group that is seeing an increase, whereas others are not. And actually, the age group that we're most concerned with are 5 to 12-year-olds. That's the age group that is increasing at the fastest rate over the last few weeks. So yes, they have underlying conditions. They're a vulnerable population. Maybe their immune response wasn't quite as high to the vaccine, but so there's multiple reasons. I'm going to turn it over to Dr. Hahn to see if she can add her perspective.
Yeah, absolutely. Remember that even though we're pleased that we're, approaching 80% across our senior population, that leaves a lot of unprotected seniors. And yes, our data is a little bit delayed by the time you mentioned just this week a jump. So we always look and see of our hospitalized patients. We match that with our immunization registry, so we know. Again, it takes us a while to do that process, but what we're hearing from the hospitals continues to be that the folks they're seeing in the hospital are unvaccinated. I just had a good conversation. I have a good friend who's a doctor at St. Al's, and she was on call over the weekend and was just exhausted. And I said, "Are they still unvaccinated?" She said, "All of them." The people she saw, they were all unvaccinated, and she was so frustrated. So I do think that we're seeing that same thing in our seniors. Again, yes, of course there's the rare exception, but we do believe that we're seeing the unvaccinated, vulnerable population with this very, very contagious virus that is now getting very sick from the virus.
Okay, our next question is going to come from Joe Parris.
This is Joe Parris with KTVB in Boise. I'm curious if anyone on the call has general data or information about the vaccine uptake over the last few weeks, since specifically the FDA did give the formal approval to the Pfizer vaccine. I'm curious if there's been a noticeable increase in vaccines or if it's stayed pretty steady.
Yeah, thanks, Joe. We have seen a little bit of an uptake, but I'm going to let Sarah Leeds cover that question.
Thanks, Elke. Yeah, we have seen for the past several weeks, I want to say about 4 weeks, an increase in weekly dose administration. We typically update our internal numbers by the week, by this afternoon, but it seems like this week we have not seen that increase, but I need to see the final numbers before I confirm that. So we last week over the week before, we saw a 2.3% increase in the total weekly administrations.
Okay, our next question is going to come from Audrey Dutton.
This question is for Director Jeppesen. This is a tough question. In communities with high infection rates and low vaccination rates, are children and teachers safe in schools that aren't requiring masks for all staff and students? And I ask, since parents are having to make yes or no choices about whether to send their kids to school, could you please answer yes or no?
Well, obviously, a goal we have is to have our kids in school and to have that be as safe as possible. And the two things that make that as safe as possible are, as one is having the adults, the 12 and older, get vaccinated. We know that's highly effective. And the other is the data is very clear that wearing a mask for both students and teachers is highly effective in preventing spread. There's a recent anecdote of I forget, maybe Dr. Hahn can remind me where that was from, but of a teacher that was infected, unvaccinated, infected, and ended up infecting many of the students in the classroom, as well as then taking that home to parents. And actually the data was interesting on that because it was actually got all the way down to where the kids sat in the classroom as to who was at highest risk for that. And so the safest way to keep kids in school is for the adults to be, and the 12 and olders to be vaccinated, and for those kids and adults and visitors that are in the school to wear a mask. That's consistent with CDC guidance. That's the guidance that we've given that Elke mentioned on the State Department of Education website. And that is the safest way we know to keep kids in school.
But are they safe?
You know, I think the answer to that is that if the safest way to keep them there is to follow those safety protocols.
Okay, we'll move on to our next question, and that's going to come from James Dawson.
Hi, maybe this is for Director Jeppesen, I suppose. Would you approve a recommendation or a request from hospitals looking for, crisis standards approval to prioritize patients based on their vaccination status?
James and Audrey are bringing out the tough questions here at the end. Thank you, James. That's an excellent question. The crisis standards of care are actually already written. They're available on our coronavirus.idaho website. And what they are is a set of guidelines and protocols as to how to handle when you have a scarce resource situation. And to the best of my knowledge, those protocols do not include a criteria around vaccinated and unvaccinated. It has to do with a holistic assessment of both the patient as well as the resource shortage that exists. And what we will follow is what we have in those standards. They were written based on national best practices, as well as a physician community across the state spent many, many months actually writing those very delicate and sensitive protocols for how you handle crisis standards of care. And so we will defer to those, and unless one of my staff knows differently, there's not a guidance in there around vaccinated versus unvaccinated.
You're correct, Director. There is not, and Nikki did put in the chat the link to the crisis standards of care documents.
Thank you.
Okay, our next question is going to come from Melissa Davlin.
You spoke briefly about the timeline for the monoclonal antibody treatment center in North Idaho. Can you give us a timeline for the two in Treasure Valley and Eastern Idaho? And are those going to be set up in enough time to make a difference for those hospitals that are experiencing such strain right now?
Yeah, thanks, Melissa. Dr. Hahn, do you want to continue on with the topic?
Sure. Okay. Yeah, the short answer is no. We're very pleased that we feel like we have partners and a plan up in Northern Idaho. And the team that's working on this for health and welfare has now turned their attention to identifying partners and locations in the rest of the state. However, we're not ready. Talking to the team just today, we got a little update, and I don't think we're ready. As to your question about is it going to be in enough time, we can't say for sure, but I do know, I think early in this pandemic, we thought, well, if we can't just think quickly, what's the point? The wave will have passed by the time we get ready. I don't think that's going to happen. I think even if it takes us a couple weeks to get the other sites set up, that they will be useful going into the fall respiratory season. I think we're going to need to have all hands on deck, all stops pulled out as long as possible. So yeah, I think it'll be in time to be helpful, even if it takes a few weeks.
And just to clarify, we don't have a target date or a time necessarily when those two in Eastern Idaho and Treasure Valley are going to be set up.
Right. I'd say as quickly as possible. And because the state is not themselves going to have to implement, we need to really just build those partnerships and get them the funding. We're already turning our attention to the other two sites. So I'm hoping that we'll very quickly have them identified and have funding to them. But obviously, I can't give a timeline, but I think it'll be very shortly.
Thank you.
Okay, and it looks like our final question today is going to come from Audrey Dutton.
This question is for Dr. Hahn. How is our oxygen supply in Idaho? We've seen some of the southern states struggling with that.
Yeah, thank you, Audrey. I was actually on Kootenai Health's Facebook page a few days ago, and they have some dramatic pictures of them bringing in a larger oxygen tank, that their tank was not big enough for the number of people they have now requiring oxygen. Right now, we have heard that we're okay, but we are watching very carefully the news from, as you mentioned, southeastern United States, where they are starting to have constrained oxygen supply, and we are worried about it.
Okay, and with that, we'll wrap it up for today. Thank you everyone for joining us today. We are planning another media briefing at 2:30 p.m. Mountain Time on Tuesday, September 7th. So I'm sure we'll see you all then. Thanks.